Let's start with the first case. The previous history is a male, 51 years old, current smoker and obesity, and the current admission is due to an inferior STEMI of 2 hours in length. The primary PCI is indicated, and the pre-hospital treatment is only with aspirin, 250 milligrams. This is the coronary angiography. It's performed by radial access with full dose of heparin, and we can see a thrombus in circumflex, and we can see the coronary right artery that is occluded. And then we have a question.
First question is a patient, remember that is a patient that comes from an acute myocardial infarction. And according to these images, which antithrombotic treatment would you start? A PCI with loading dose of ticagrelor prasugrel at the end of the procedure, PCI plus bolus plus infusion 2B3A inhibitors and ticagrelor prasugrel at the end of PCI, PCI plus bolus infusion of cangrelor and transition to clopidogrel, or PCI bolus plus infusion of cangrelor during PCI and transition to ticagrelor prasugrel. What's Raúl, your opinion?
I would vote for the four. This patient has not been pretreated with, it's only with aspirin, has not been treated with ticagrelor prasugrel or even clopidogrel. I think this is an ideal scenario for cangrelor. And then, of course, transition not to clopidogrel but to ticagrelor prasugrel. This patient is also apparently a low risk of bleeding patient, 55-year-old patient. I think it is a clear indication for cangrelor.
Stephan, you have...
I probably would have taken option 2, so the infusion of a GP2B3A inhibitor followed by ticagrelor and prasugrel. Clearly, it's a very challenging patient. It's an ectatic coronary artery anatomy with thrombus in the circumflex. In the right, you already know that you have issues with no reflow and so on. So that would be my strategy.
Okay. Only very few brief comment. According to the guidelines, probably the first option is the option according to the guidelines. But I understand it's a very complex case, and something new should be added. And I also agree that it is a good opportunity for cangrelor in this case.
Anything different, Fernando? No, you have the micro on your head.
No, we don't.
You don't need the microphone.
You don't need the
on your hand.
So, thank you. We don't have the cangrelor, but obviously, as Raúl was mentioning, it was a good strategy, and we will proceed nowadays without 2B3A, but just conventional treatment. I wouldn't wait for the end of the procedure to administer, ticagrelor or prasugrel. We'll try to do that, as we discussed yesterday, on the table as soon as possible.
Okay, let's move on with the case.
Okay, the operator decides to give a bolus of axiximab and then implant a biodegradable polymer stent. This is the final result. We can see a little bit of thrombus in the proximal segment, and also we can see a slow flow, partial reperfusion in the posterior descending artery. And despite this result, the operator decided to treat also the circumflex artery, and we can see the final result. And at the end of the procedure, the operator decided to give a loading dose of ticagrelor. In hospital course, the patient is admitted to the ICU, hemodynamically stable and asymptomatic, and 5 hours later, patient presents chest pain and inferior ST re-elevation, and new emergent coronary angiography is indicated. Now the procedure is performed by femoral access, because the previous had been performed by radial, with 3,000 units of heparin, and we can see that the circumflex has no problem. And when the operator goes to see the right coronary artery, that's happened. We can see aortic dissection, and also we can see a stent thrombosis. Wow. In this moment, the operator decides to change the catheter for an AR2 guiding catheter, with severe difficulty cross the wire, and then decide to implant another drug-eluting stent. This is the final result, and flow is acceptable, but we can see the progression of dissection. The orthography, we can see the double lumen sign, and here we have a new question.
And now you have another problem, no? You have an acute stent thrombosis or an acute scaffold thrombosis in this case, no? And we have a complication of the procedure because you have one situation that we want to put on a bigger treatment, but we have an aortic dissection. What would your strategy at this moment, Dr. Morais?
It's a very difficult decision, a very difficult situation, but of course we should consider surgery. I know a lot of problems with surgery in this case, and our colleagues, our cardiac surgeons, probably they will discuss a lot because they don't want to manage patients under an aggressive antithrombotic regime. But of course, my first option is to send the patient for surgery and discuss the patient with the cardiac surgeon.
I think it all depends on how stable the patient is. So, you know, I think what I would like to see is an echocardiography. Is there any evidence of aortic regurgitation? Is there any evidence of pericardial effusion? Now, in the absence of an GP2B3A inhibitors, there is a good chance that this may spontaneously heal. So I think I would do, my strategy initially would be to try to delay surgery and do it only if it is absolutely necessary. I mean, this is a guide dissection, and it did expand with the repeated injections, yes, but I'm not convinced at this point in time that surgery is already absolutely needed.
Mm-hmm. So, unique case. I mean, it's impossible to find a case where at the same time of stent thrombosis you cause iatrogenic aortic dissection. So there is no data on that. I mean, the experience with these type A proximal dissections is very good. I mean, if you just go for a conservative strategy, watchful waiting. The only thing that this is pretty ugly. But even in ugly cases like this, I would say that most of them just heal spontaneously, just checking with CT or transesophageal echo. I will try to be conservative because in a large series we did in the clinical San Carlos and additional studies, I mean, the progression of that to a stroke or a death is low. So I will try to be conservative. And also, the therapy is very challenging.
Okay, Raúl?
I would also try to be conservative. These patients with iatrogenic aortic dissection usually have a good prognosis when left on conservative treatment, especially when it comes from the right coronary artery. It's not always true when it comes from the left main. I would be very sure that we have sealed the ostium of the right coronary artery with a stent. And finally, regarding the drugs, this is in the previous question. In my center, we don't have GPA inhibitors already. Now we use Cangrelor. Fernando is in the opposite situation. He doesn't have Cangrelor, but he has GPA inhibitors. This is an example how the short life of the Cangrelor may be an advantage in extreme situations such as that.
Patient on AV65, is this true?
Yes.
Okay.
Only bolus during the first.
Only bolus.
Only
Okay,
bolus.
it's different. Only bolus.
And
The first,
of ticagrelor.
So yeah.
First PCI. Okay, let's go on with the case.
The patient is admitted in the ICU, stable and asymptomatic, and initially conservative treatment is decided and control CT is performed. This is the CT. We can see the progression of dissection that involves the supraortic trunks, but also involves the ascending and descending aorta. Finally, surgical treatment is decided given the extent of the dissection, and we have a question.
Yes, you have the patient with this complication, and now you have to prepare the patient to go to the surgery, and patients are received a loading dose of ticagrelor at the end of the procedure and a apixaban bolus in the first study that was 5 hours before the second. What would be your antithrombotic strategy before surgery? Platelets, which will reverse the effect of apixaban and ticagrelor. Platelets, although they will only reverse the effect of apixaban. Platelets and rescue fresh frozen plasma. The surgeon is making a pressure over you to how to treat the patient to avoid the surgical complications.
Platelets, probably with double the dose it is usual to use to reverse antiplatelets effects. We know that platelets are not reversing the effect of ticagrelor, this is true, but platelets and high dose of platelets are enough, at least for the first few hours for surgery. So the cardiac surgeons are more confident managing these patients with high dose of platelets. And fresh frozen plasma is an option, but they don't reverse anything.
Yeah. Anything different? Okay, let's move on.
Despite platelets and plasma, the patient presented a massive hemorrhage and finally died during the surgery.
Hemorrhage from the aorta?
Yes.
Yeah. Okay, what was the first case? There is a setting that, as Dr. Moreno said, we need some drug that has the effect that the half-life should be the shorter as possible, because we have to, you can have problems like that. It's a disaster for the patient. No? Okay, let's move on to the second case.
Yes, it's the previous history is a male, 79 years old, former smoker, weight 55 kilograms, hypertension, diabetes, and COPD with FIV1 1 liter. The cardiac history is severe aortic stenosis with Vmax 4.3 meters per second. The gradients are 70-45, and the A/A is 0.7 square centimeters. The functional class is 2, and the current treatment is aspirin, ACE inhibitors, and bronchodilators. The patient is pending decision of the heart team. The current admission is due an anterior STEMI, and for this reason, the primary PCI strategy is indicated, and the pre-hospital treatment is with aspirin 250, ticagrelor, and heparin milligram per kilo. This is the ICG. We can see an anterior elevation. And this is the right coronary. The patient was performed a coronariography before, and we can see the stenosis in right coronary artery in the middle, 70%. And this is the left anterior descending, and we can see a severe lesion in the proximal segment, and also we can see a radiolucent image in the middle of the artery. At this moment, the operator decides to treat the lesion with a BMS stent after predilation. And this is the result after stent implantation. We can see the radiolucent image in the middle. And for this reason, the operator decides to implant a second BMS with final post-dilation with ANC balloon. This is the final result. You can see a good result. And then we have a question.
We have a question. Remember, this 79-year-old male that they are pending the decision for the treatment of your aortic stenosis. No? At this moment, the patient presented with an acute cardiac syndrome. Which antiplatelet treatment would you prescribe of this patient? Is elderly, low-weight patient, downgrade from ticagrelor to clopidogrel plus aspirin. High-risk stent thrombosis, switch to ticagrelor to prasugrel, only 5 milligrams once a day. Keep the same treatment, I think it's good. or I would be enough with ticagrelor only 90 milligram twice a day without aspirin. Dr. Moreno?
Yes, I think in this case I would keep the same treatment. So probably we now have a trial that compared ticagrelor to prasugrel and the results were in favor of prasugrel. But I think that if a patient is already with one drug, I think we don't have enough evidence to change the drug. I would maintain on ticagrelor not to downgrade to clopidogrel because it's a clear acute myocardial infarction with high risk of ischemic events.
Yeah, basically the same. I think there is no a strong reason to make a change, I would say.
Dr. Windecker,
I think
the same?
The same.
The same. Okay, let's move on with the patient.
The initial evolution was correct. The ETT shows normal ejection fraction with circumscribed apical akinesia, and the team decides to do a downgrade from ticagrelor to clopidogrel the day after PCI. However, in the 5th day of admission, new episode of chest pain and anterior ST elevation, and for this reason, the primary PCI is indicated. And this is the ECG, even worse than the first. And this is the LID. Now is total occluded. The operator decides to administer an abciximab and perform a thrombectomy. And this is the angiography of the eye after thrombus aspiration. We can see a high burden of thrombus, mainly in the overlap zone. And for this reason, decides to perform a multiple dilations with NC balloon. And this is the final result with TIMI-3 flow. And now we have another question.
Always we have in the same situation because we prefer to make a downgrade of the patient, but when we have a complication, you put into 2B3A. So stent thrombosis are reasonably well opposed and expanded device. Which antiplatelet treatment would you prescribe now? There was no antiplatelet problem. I would prescribe clopidogrel and aspirin because I thought that was a problem with the stents. Downgrade from ticagrelor to clopidogrel in the acute phase may have played a role. I would change again to ticagrelor and aspirin. Because of the stent thrombosis, switch to clopidogrel to prasugrel. And I would add rivaroxaban to 2.5 by the day to current treatment.
Let me ask a question.
Yeah.
When switched from ticagrelor to clopidogrel, the patient was reloaded with clopidogrel? No.
The day after the PCI.
Okay, but was reloaded when switched to clopidogrel?
Yes.
Okay.
What's your decision? What
decision,
treatment?
my decision is to go back to ticagrelor, of course. So of course, there is.
I mean, the only issue is that you need to have an OCT after the procedure. It's not good enough to do the OCT, see what you see, go for a non-compliant balloon dilation, but you need to check because perhaps there was also some residual underexpansion. I mean, there was some underexpansion, but the LED was huge, so perhaps this underexpansion is not just the normal tapering. And then I will go to 2 or 3. I mean.
We always perform an IMAT technique when you have a stent thrombosis to roll out some underexpansion, malapposition, or something else to decide to change the treatment, or it's a mechanical problem. No? So let's move on with the case.
The team again decides to switch from clopidogrel to ticagrelor. The ETT shows the similar ejection fraction, and patient was discharged from hospital on the 5th day. The follow-up, the scheduled right coronary PCI performed 2 weeks later. And 1 month after discharge, the accurate TAVI is implanted with good result. But 2 days after TAVI, patient refers dizziness and palpitations. This is the ECG, the anterior necrosis, But now, patient is in atrial fibrillation with rapid ventricular rate. Amiodarone bolus and infusion was started, getting rate control but no reversion to the sinus rhythm. Now, we have a question.
It's difficult to know what is the end of the patient. No, sometimes we have another complication, another problem. Now we have the patient with a stent implanted one to 2 months ago. TAVR is put 2 weeks ago. And now the patient is in atrial fibrillation. Which antithrombotic treatment would you prescribe? Aspirin, clopidogrel, and direct anticoagulation, aspirin and direct anticoagulation, clopidogrel and anticoagulation, ticagrelor, direct anticoagulation. Any other option? I know you have put this, but others are possibly.
So the TAVI was how long after the intervention
2
of the
weeks.
right?
1 month. 2 weeks?
1 month.
1 month.
1 month. 1 month after.
1 month after
1 month.
surgery, sorry.
Yeah, theoretically, it's not vitamin K antagonist. The options, theoretically, the guidelines recommend for the first 3 months after the TAVI, vitamin K antagonist. But anyway, here's NOAC. I would vote for the one because I would prescribe here double antiplatelet therapy, so triple with the NOAC because of having several stents on the LAD, having suffered stent thrombosis. I think only one drug, but I think aspirin, ticagrelor, and NOAC is too much. So I think in this difficult decision, I would vote for the one.
Me too. I'm also in favor for the first option because 1 month later, even though the bare metal stents is a complicated situation with the thrombosis, good stent thrombosis before, so they need 2 antiplatelet drugs, in my opinion. And aspirin plus clopidogrel and NOAC is a good option. I think so.
So the question would be how long you give it, the triple therapy.
Yeah, of course.
The second question.
Yeah.
Yes, of course.
Yeah. Okay.
Aspirin and NOAC was prescribed, adequate subsequent evolution, and finally the patient is discharged 5 days after the procedure.
Okay. Any comment from the audience from this case? What do you think was the possible mechanism for the stent thrombosis after the implantation of the first stent? Do you know?
I would expect under expansion because in the images prior to the stent implantation, you saw extensive calcification. Then you had overlapping stents. I would assume it was a mechanical issue. But can I ask? So the patient had a diagnostic evaluation and was in the heart team discussion, we treated, and then he developed that ST elevation myocardium function. That's what happened. Okay. Which is rare and unusual.
No,
And another question is, in general, what do you treat first, the coronary artery disease or the aortic stenosis? I'm rather surprised that he tolerated that hemodynamically twice because it was a large wraparound LED.
My comment will be that we don't know the cause of stent thrombosis in this patient. I mean, obviously, if you do OCT and you find underexpansion and perhaps a little bit of malposition, you should tackle this. You should correct that. But most of our patients in everyday clinical practice, I mean, they got underexpansion, 60%, and they survive without any event. So if you recognize a problem, you should treat it for sure. I'm not convinced that this is the guilty. I mean, because there was this underexpansion, the stent thrombosis, but you should address that.
And then you think the downgrade from ticagrelor to clopidogrel can play a role in this setting?
In this case.
Okay.
You have a question?
Yeah. The question?
Sometimes
comment?
difficulties. Okay, so we have sometimes difficulties to define who are the patients who can be candidates for the potent P2Y12 inhibitors with anticoagulation. But I think that those who suffer a stent thrombosis on clopidogrel are those patients who are definite candidates because they prove they had a stent thrombosis event on clopidogrel. So I think we should switch them and not only optimize the interventional aspect, but give a more potent treatment, which is in this case ticagrelor in addition to NOAC. Whether you should keep it for the 1 year duration or switch it back later is a question, but I think we should not only react on performing a repeat intervention, but also optimizing the antithrombotic treatment. So stent thrombosis patients may qualify for the potent P2Y12 inhibitors, even with NOACs. I don't know, what's your opinion?
No. Thank you.
You know, I think another point
question?
of discussion is obviously what is the significance of periprocedural atrial fibrillation in the setting of transcatheter aortic valve implantation. Is it really the same as spontaneous atrial fibrillation at some later point in time? I do not know.
Probably not.
And we also don't systematically anticoagulate all patients that have periprocedural AFib after surgery. So
Exactly, probably exactly the same, because a lot of patients are suffering atrial fibrillation after surgery.
well,
and,
I
meaning
just
of
say I
the
don't know, but I think it's worth
Big studies detect 10 to 15% of atrial filling onset of atrial fibrillation after TAVR, and more than 30% after surgery.
Yes,
It's not an irrelevant problem, no?
I have a comment in the same line.
comment?
Surprising for me to see that over half of the people generally was able to put the patient on ticagrelor or anticoagulation, because it's 1 month after PCI. We know the thrombosis risk is very dynamic, and the thrombosis risk after 1 month with bare metal stents is really low, and it's becoming lower. But the risk of bleeding with ticagrelor and anticoagulation is going to increase, and it's going to be very high in the first 3 months. Then, in my view, in this case, I would prefer to put, like you did, or anticoagulation plus one agent, maybe clopidogrel, better than aspirin, I don't know, one of them. But to combine ticagrelor with anticoagulation, just because there was a thrombosis 3 weeks ago in a patient that has 1 month after PCI with bare metal stents that are 3.5 millimeters, maybe was dilated very nicely in the last procedure. And I think it's to overestimate the risk of thrombosis that is really declining, definitely, and not really being very aware of the bleeding risks. And in my opinion, we cannot, I think we are always very concerned about thrombosis risk because it's our business. We see MIs. And bleeding is the business of other people. We don't see these people in the GI unit, we don't see these people in the genitourinary unit, we don't see these people in neurology with bleeding. And the cardiologists are always driving to think that the thrombotic event is the worst. And the bleeding is an nuisance, something that can be nothing. Then I think it's surprising for me that we are very aggressive sometimes.
But it is very controversial to remove P2Y12 inhibitors in this case, only aspirin.
No,
Oh, it's okay. Maybe.
But ticagrelor plus anticoagulation is too much in this case.
In this case, maybe, of course, we may have an explanation, a mechanical explanation for stent thrombosis, but maybe this case is ideal for detect clopidogrel resistance, because if we are going to prescribe only clopidogrel and NOAC, and the patient has resistance to clopidogrel, we may have another event.
Okay, let's move on to the third case.
This is the previous history is a male, 77 years old, hypertension, diabetes, and COPD. The cardiac history, patient has a three-vessel disease with normal ejection fraction, but he was rejected for CABG, and for this reason, right coronary artery PCI was performed 5 months before, and the current admission is to schedule LID PCI. We can see the right coronary artery, the stent is patent, but we can see a diffuse DC in the distal segment. We can see a subocclusive lesion in the posterior descending artery, and we also see a ostial lesion in posterolateral and in marginal branches. And this is the LID. We can see a severe and diffuse disease, mainly in the middle of the LID.
Left main is normal? I can see it.
Yes.
Okay.
Yes.
Okay.
And at this moment, the operator decides to do a multiple dilations with conventional balloon, then multiple dilations with NC balloon. And this is the result after balloon dilation. Here down IBUS, we can see a high burden plaque. And after IBUS, the operator decides to implant a drug-eluting stent in the distal and in the middle of the artery, also drug-eluting stent. And this is the result after second implantation. Now we have a question.
Okay, you have a patient with a very diffuse disease. We implanted 2 drug-eluting stents. As you can see in the echo, this is a calcified artery with a large plaque burden. So would you post-dilate this drug-eluting stent after this angiographic result? Yes, this is a very calcified vessel. Obviously, always I post-dilate these lesions. Now drug-eluting stents are correctly implanted. Not all the cases have complications. Sometimes have complications. No, don't think that. No.
I'm not interventional cardiologist. It is easy for me. I'm not interventional cardiologist. They decide.
Yeah.
I mean, you don't know if the result is perfect or at least correct unless you do coronary imaging. I mean, the only thing is that in this very long lesion going nowhere, going to the apex, perhaps with the initial result after balloon dilation, a drug-coating balloon could be just an alternative. But having said that, I mean, if you want to be sure, you need to check with OCT, for instance. And probably we will get a perforation at the end.
No.
No, I agree. It's a very extensive long lesion, and you should optimize it with OCT, and then depending on this, decide what you do next.
In this case, you have an IVOS that we are ready to take the IVOS previously.
Yes.
So, but with the result, no, because I think there is in the mind of a lot of interventional cardiologists, the concept is when you put 2 drug-eluting stents, 2 overlap stents, you have to post-dilate the overlap. No, I think sometimes.
I could post-dilate also. I could do intracoronary imaging, but if not, I could post-dilate, especially in the image we have seen, the mid part of the, I don't know if it was in the second stent, at the distal part of the second stent, I don't know where, but I think there was some under-expansion, angiographically at least.
Okay. The audience also think that they have to post-dilate this lesion. So let's move on to see what happens.
Perforation, of course.
Yesterday case was a spoiler of this.
Yeah, of course. Quite expectable.
It doesn't matter. We can learn something different. This is the result after post-dilation. In this moment, the operator decides to do a multiple balloon inflation up to 25 minutes. And then we have another question.
So you have the problem, you have the situation. We have a perforation that is closed with a prolonged inflation. This is balloon in place. And we are transitory solve the problem. You do administer, always do you administer protamine when you have a coronary perforation? Yes, full dose of completely reverse the effect of heparin. Yes, but only a partial reversion. No, I would implant a covered stent.
I could implant the covered stent, but also I would reverse at least partially the heparin.
The heparin.
Yeah, because probably if you completely reverse the effect of heparin, probably you are getting new problems.
Yeah.
So.
I would watch and see if the patient is stable, pericardial effusion, I would keep the balloon inflation, not do anything with the anticoagulation, and then after a few minutes look how it looks, whether it looks improved or not.
But the covered stent
at this moment, the patient is stable with no pericardial effusion at this moment.
So it may be in contained.
With the balloon.
So in other words, you may not need a covered stent.
Okay. The audience thought that they put a covered stent without reversing the.
The operator decides to administer protamine and RAF stent implantation. And this is the result after RAF stent implantation. The reversion was only partial. And then?
Now you have the next problem. No, we have only partially reversed the heparin. We have 2 drug-eluting stents, 1 covered stent, transient solved to the coronary artery perforation, but we have now TIMI-0 flow. What would you do now? Thrombectomy? We are moving to the other place, heparin plus glycopyrrolate to B3A inhibitors, even local thrombolytic agent administration. Send the patient to the surgery because we are moving on the very dangerous situation. What's your opinion?
Surgery, of course, is not an option. Local thrombolytic agents, of course, is not an option. So the question is to perform thrombectomy plus something else. Not thrombectomy alone, but thrombectomy plus something else. And of course, GP2B3 inhibitors, they are always a good option. But we start with thrombectomy and we'll see.
I would try to go home, but if not possible, I would use thrombectomy and maybe heparin also.
Yeah. Okay. So we will probably be progressive in the aggressive situation, no? Okay. The audience thought we have to start with thrombectomy, so let's to see what the operators did in this case. I think they move too much fast at the end.
10K. Oh, great.
The spoiler.
Yes. The operator decides to administer a TNK intracoronary, and this is the final result. Patient is transferred to the ICU, severe hypotension 90 minutes after procedure. The ETT shows several pericardial effusion that requires pericardiocentesis and blood transfusion, but finally patient is discharged 7 days after the procedure with aspirin and ticagrelor.
The operator was very brave to put fibrinolytic therapy in a patient that will have a coronary perforation. No, any comment in this case?
Comment was. It's difficult to understand this decision about TNK, but okay.
Okay, any comment in the audience?
I think that the stent graft doesn't always seal 100%.
Yeah.
Proceed well, thrombosis is good for sealing the rest. If you have thrombolysis, there is even a very minimal leak is able to continue the drainage to the pericardium, and things was too aggressive.
No, but yes. In general, sometimes we have to post-dilate a lot the covered stents because sometimes they don't close totally the perforation. No? So probably they don't seal and the patient will make the tamponate after the procedure, no? During stay in the coronary unit.
Let's say that the patient after the pericardiocentesis bleeds again. Yeah. So you call the surgeon and you say what? Because it's a full metal jacket in the LAD, the apex. So the surgeon, what can do the surgeon there?
Drain the effusion.
Avoid the bleeding, no? I think to put the... But it was very difficult to call the surgeon after thrombolytic therapy.
Oh my God.
It's difficult with to be 3A, but even after thrombolytic therapy.
It's worse.
But sometimes I think there are centers in our center with perforation that are not solved with the stents. We send the patient to the surgeon, and the surgeon always solves the bleeding problem. They put a part, they put something that avoids the bleeding, and the coronary artery, we don't know exactly what the final result. No, because that time, with the full metal jacket, it's very difficult to put a bypass in this LAD. No?
Yes, of course.
We have time?
Okay, yes, we have time for the 4 case.
This is the previous history. It's a male, 55 years old, weight 70 kilograms, current smoker and occasional cocaine consumer. He also is hypertension and dyslipidemia without treatment. The current admission is chest pain for 7 hours. The ECG shows less than 1 millimeter of ST elevation in the one ABL leads, and initially treated with subcutaneous enoxaparin, aspirin, and clopidogrel. Primary PCI strategies indicated due to the person's state of ongoing symptoms. This is the right coronary artery that is normal. And this is the left coronary. We can see total occlusion in the diagonal, but also we can see a severe lesion in the proximal circumflex. At this moment, the operator decides to administer a bolus of enoxaparin and decides to treat the diagonal with BMS implantation. And due the procedure was very easy and the result was very good, he decides to treat also the circumflex with drug-eluting stent. And this is the final result. And this, we have a question.
Yes, this, remember, there is a young male, 55 years old, which antiplatelet, they receive aspirin and clopidogrel was a loading dose at the beginning of the procedure. Which antiplatelet treatment would you choose to send the patient home? Aspirin plus clopidogrel 12 months, aspirin plus ticagrelor 12 months, aspirin prasugrel 12 months, aspirin ticagrelor 1 month followed by 23 months of ticagrelor monotherapy, global leaders treatment. Aspirin ticagrelor for 3 months followed ticagrelor monotherapy, the twilight strategy. What's your opinion, Raúl?
3. I would prescribe prasugrel if the patient is on clopidogrel before the PCI. He needs ticagrelor or prasugrel, and in STEMI I would prefer prasugrel for 1 year.
2 or 3.
2 or 3. 2 or 3.
2 or 3? Okay. 2 or 3. The audience are on the same line of the panelists, so let's move on. What happens?
Patient is treated with aspirin and clopidogrel. The fraction ejection is normal without wall motion abnormalities, and patient is discharged 4 days after the event. In the follow-up, the cocaine consumption the same day of the hospital discharge, and 1 hour after consummation, the patient presents a new episode of chest pain. This is the ECG. Wow. We can see a elevation in 1 and ABL leads.
So cocaine was prescribed.
Yes. And this is the first injection. We can see a simultaneous subacute thrombosis.
Wow.
And
at this moment, we have a question.
So the patient was very happy from the discharge and they celebrate with cocaine. Now we have the patient on the table again. And which antiplatelet treatment would you administer in this situation? Loading dose of ticagrelor or prasugrel at the end of the procedure. Only 2B3A inhibitors, bolus, and ticagrelor or prasugrel at the end. Bolus and infusion of 2B3A inhibitors. And after that, ticagrelor or prasugrel. Bolus plus infusion of cangrelor and ticagrelor prasugrel at the end of the procedure. Dr. Morais.
I don't think that GP2B3 inhibitors are not needed in this case, at least at this moment. Mm-hmm. Of course, we need to upgrade the antithrombotic regime, the antiplatelet regime, and the options of ticagrelor and prasugrel are good options. But in this acute phase, probably to start an infusion of cangrelor is a very good option, and at the end switch to ticagrelor or prasugrel. And teach the patients to celebrate with red wine, not with cocaine.
Okay, Dr. Windecker, what's your...
So he was discharged on clopidogrel?
Yes. Yes. And this is the same day of discharge that presents with the event.
Yes. So, you know, it's funny, this morning I heard stent thrombosis is so rare, it doesn't occur anymore, but this every single case. And what I think is concerning in this case is that both stents are occluded, and I probably in that setting would choose an GP2B3A inhibitor just for the procedure and then escalate to ticagrelor or prasugrel afterwards.
Okay.
I will also use 2B3A plus sucralor or ticagrelor. I mean, it's 2 stents.
Yeah.
2 stent thrombosis, yeah.
And it was a good result.
Yeah. So let's move on. Oh. Huh? What happened?
Okay, at this moment, the operator decides to treat the diagonal with balloon dilation and decides to administer abciximab intracoronary, and then he is done a thrombectomy in diagonal artery with this result, and he also treats the circumflex artery with balloon dilation, but this is a NC balloon. And this is the final result. The abciximab infusion is maintained 12 hours post-PCI. And the team decides to start ticagrelor, and at 5 days, the controlled coronary angiography is performed to assess residual thrombus. This is the angiography.
It's cleaner.
Yes, it's clean. And this is of the eye. We can see a little bit of thrombus, but we can see a correct position of stent. This is the diagonal artery. We can see a residual thrombus, and this is of the eye of circumflex. We can see also the thrombus, and we can see a correct position of a stent.
It's curious that it's 5 days after stent thrombosis and treatment with 2B3A, bolus and perfusion, and this is a residual thrombus 5 days after, and the patient was on aspirin and ticagrelor.
In the follow-up, the patient is asymptomatic after 5 months in treatment with aspirin and ticagrelor.
Yes. Any comment for this case? No. So you are making a lot of studies to found any other drug to has more effect, more antithrombotic effect, less bleeding, but probably you have to think about another formulation to have ticagrelor with inhaled ticagrelor for this patient, not because not abuse the cocaine or the ticagrelor, no? Can be a solution. Is a comment?
I'm curious about the checkup angiography.
Yeah.
What is the clinical decision if you find residual thrombosis, and so what? Is this an academic study or is it a clinical study? I mean, what is the decision that you change? Because I don't allow my colleagues to make studies if you're not going to make a change in your treatment, because then I think it's academic. Doing a second angiography, you're not going to change anything if you find whatever you find. I'm not sure what is the meaning of this angiography.
We decided to perform the second angiography because in the first angiography, when you end the first with the stent thrombosis, these are residual thrombus that you can see in the angio. No, the left circumflex artery is a thrombus, and in the diagonal. In the second treatment, there is not apparent thrombus in angio, and in OCT is a residual thrombus. I think the decision was to maintain the patient with aspirin and ticagrelor. If the thrombus will be bigger, we take a decision. But with this amount of thrombus...
But that's my question. What decision would have you taken?
Hector,
put a second stent, put another thing to treat Hector, the thrombus. I don't know, because no, I don't know. No. Probably
when you plan this strategy, you need to have a plan. You just can't go and see and then improvise.
Well, Hector, but this is what we usually do. I mean, this is a patient with a thrombosis of 2 stents in 2 different vessels, and at the end of the result, there were some haziness in the 2 stents. So this is not, I mean, you are very unsecure of that. So that while the patient is in the hospital, then before, 3 or 4 days later, in those cases, we try to check try to be reassured that the whole thing is clean, and if you do OCT, perhaps you are more reassured. Now, the question is, what happens if there is something ugly there? We don't know the answer, but I think knowing the information could be of help. We don't have any data, but if there is a thrombus which perhaps is silent, or there is a huge thrombus, perhaps you will react to that.
Yeah. I definitely agree with you, but in this particular case, Hector, the thrombus is very close from the osteo or the diagonal branch. The risk of progression to the LAD is obvious. I think that my colleagues in the cath lab probably they will defend exactly this approach. A few days later, okay, let's recheck the anatomy, particularly to the risk of the involvement of LAD. And but I agree with you.
I work in the CCU, so we have these cases not often, but from time to time. I'm just skeptical about that strategy.
No, and sometimes when we see high burden of thrombus, we put subcutaneous henoxaparin for a few days for treatment, if the high burden thrombus. Yeah.
Okay, so we end this session with 5 years in advance. So probably it's very interesting cases that we have to solve several problems and to learn more about the antithrombotic, antiplatelet therapy with different situations that you can have in the real life. Okay, thank you for your collaboration.